So, imagine a scenario where the saliva in your own mouth, like the stuff you naturally swallow effortlessly 1,000 times a day, suddenly becomes this highly destructive acid.
Right, an acid that's literally threatening to rupture a major artery in your neck.
Exactly. I mean, it sounds like something straight out of science fiction.
It really does, but it is a very real, very terrifying biological reality.
Yeah, so today, you and I are stepping into the intensely complex, high-stakes world of head and neck surgery. Welcome to this deep dive.
I'm really excited to get into this one.
Me too. For this deep dive, we have a really fascinating stack of medical sources to explore. Specifically, we're looking at excerpts from a text called Decision-Making in Otolaryngology.
Yeah, the sources cover chapters 132 through 136. And our goal here isn't to just, recite a dry list of surgical procedures for you.
Definitely not.
Right, we are going to unpack the incredible tightrope walk these medical professionals perform because their job goes so far beyond just eradicating life-threatening throat cancer.
Yeah, they have to balance raw survival with preserving your most fundamental human functions, like your ability to breathe, to eat, and to speak.
It's honestly a marvel.
It is. I mean, when you think about your own throat, your own voice, you probably just take for granted the complex aerodynamics and plumbing happening in there right now.
Oh, absolutely. We all do.
So we're going to trace a patient's journey through this whole landscape, from the very first subtle warning sign all the way to the almost futuristic bioengineering used to reconstruct communication.
That's a great way to frame it.
Let's start exactly where the journey begins. So a patient notices something feels, off. Maybe their voice sounds a little raspy.
Right, the classic hoarseness.
Yeah, they go to a doctor. The doctor takes a look down the throat and spots something called leukoplakia.
And leukoplakia sounds like this really definitive, intimidating medical diagnosis, but it actually translates simply to white patch or white lesion.
So it's really just an observational term.
Exactly. You'll often find these patches on the glottis, which is the anatomical term for your vocal cords.
Okay, got it.
But the crucial takeaway is that leukoplakia isn't a disease itself. It is a giant red flag waving in your upper aerodigestive tract, signaling that a biopsy is absolutely necessary.
Because the tissue is fundamentally changing, right?
Precisely.
I picture kind of like a callus forming on a guitar string. Like if you get a thick, stiff white patch on those delicate vibrating chords, of course it's going to alter the sound.
Yeah, that analogy works perfectly on a mechanical level. What you're seeing is keratin being inappropriately retained on the surface of the tissue.
Okay.
And that thick layer of keratin physically disrupts what we call the mucosal wave.
Wait, hold on. The mucosal wave, what does that actually look like in practice? Are we talking about something like a ripple on a pond?
Very much so, yeah. Your vocal cords aren't just these rigid flaps that slap together. They have this pliable, gel-like outer layer of mucosa. And when air pushes up from your lungs, it causes that mucosal cover to ripple and roll over the deeper muscle.
Oh, wow, so it's literally undulating.
Hundreds of times per second. That fluid rolling wave is what creates the rich sound of your voice.
And if a stiff white callus of keratin forms on top of it, the wave gets interrupted.
Exactly. The aerodynamics just fail, hence the hoarseness.
That makes total sense.
Yeah.
Now, the sources detail what causes these white patches. A lot of it is what you'd expect. Heavy tobacco use and alcohol.
The usual suspects, yeah.
But there was one inciting factor that really caught my eye. Gastroesophageal reflux disease. GERD.
Ah, yes.
Just have to pause on that. We're talking about standard acid reflux or heartburn from your stomach, somehow causing precancerous looking spots all the way up on your vocal cords.
It is entirely possible, and it highlights just how specialized the tissues in your body are. Well, the upper aerodigestive tract, your throat, and vocal cords is lined with mucosa that is incredibly delicate. It evolved to handle air and food, not to bathe in gastric acid.
Right.
Sometimes the sphincter at the top of the stomach is weak, or a diet triggers excess acid, and that acid literally washes all the way up the esophagus and spills over onto the vocal cords.
And because it's essentially burning the tissue, the body tries to protect itself by forming that keratin callus.
Exactly, the biological mechanism at play. Chronic irritation leads to cellular changes.
That's wild.
It is, and that is why the initial therapy for a patient with leukoplakia isn't always rushing straight to the operating room.
Oh, they'll just cut it out right away.
Not always. They aggressively target the environment of the throat first. They prescribe proton pump inhibitors to shut down stomach acid production.
Okay, that makes sense to stop the GERD.
Right, and they mandate strict vocal hygiene, hydration, and vocal rest, and crucially, smoking cessation.
The timeline on that smoking cessation blew my mind in the sources.
The 10-year mark.
Yes. The text notes that even if a patient successfully quits smoking, their cells retain a sort of memory of the trauma.
Yeah, the DNA damage is profound.
They are still considered to be at risk for tobacco-related illness for at least 10 full years after their last cigarette. That is a long time.
It really takes a long time to clear that damage out of the cellular replication cycle.
Wow.
And while doctors are always highly suspicious of malignancy with these lesions, especially in smokers, the biopsies occasionally reveal some truly bizarre outliers.
Right, the sources mentioned some crazy ones.
Yeah, the white patch might not be cancer or even pre-cancer. It could be a localized manifestation of tuberculosis, rheumatoid arthritis, or sarcoidosis.
A throat biopsy revealing rheumatoid arthritis is just wild.
It's sending right down the vocal cords, yeah.
But let's assume the biopsy comes back and it is cancer. The sources emphasize that the exact location, the specific geography of the tumor, completely dictates the battle plan.
It's the most critical factor.
So does it really matter if the tumor is sitting right on the vocal cords versus just a little bit above or below them?
It changes everything. Let's look at the area just above the vocal cords, the supraglottic region.
Okay.
Cancers that arise here are a completely different, much more dangerous beast than those on the cords themselves.
Because they present later.
Uh-huh.
Since you don't get that early warning hoarseness.
That's part of it, yes. But the real danger lies in the lymphatic system. The supraglottis has incredibly rich lymphatic drainage.
I hear lymphatic drainage a lot in medical shows.
Yeah.
What does that actually mean for the cancer cells?
Think of the lymphatic system up there not just as a pathway, but like a city's storm drain system during a massive flood.
Oh.
The tissue above your vocal cords is flush with these vessels. If a cancer cell breaks off and slips into that storm drain, it doesn't just sit there.
It gets washed away.
Right, it gets rapidly washed to entirely different parts of the neck. Because of this, there is a 25% to 50% chance of cervical metastasis.
Meaning cancer spreading to the lymph nodes in the neck. And it doesn't just stay on the side of the throat where the tumor is.
No, the cross drainage is severe. There's a massive risk of the cancer jumping to the contralateral side, the opposite side of the neck.
Jeez.
In fact, if the cancer comes back after treatment, that opposite side is the most common site of failure.
So the surgical response has to be aggressively preemptive.
Very much so.
The sources say doctors almost always recommend bilateral neck dissections for these supraglottic cancers. Like they go in and surgically remove the lymph nodes on both sides of the neck, even if scans show those nodes look completely clean.
They cannot take the risk of microscopic cells hiding in that storm drain network.
That makes total sense now.
Now, contrast that with cancer below the vocal cord, subglottic cancer. These are incredibly rare, making up only about 1% to 8% of laryngeal carcinomas.
Why are they so rare down there?
It primarily has to do with airflow and the settling of carcinogens. The upper structures take the brunt of inhaled smoke and irritants.
Ah, so the lower area is somewhat shielded.
Right. When subglottic cancers do happen, they don't cause hoarseness. Instead, because they are narrowing the windpipe itself, patients present with airway obstruction.
Or stridor, right? The sources call it stridor.
Yes, stridor, which is a high-pitched whistling sound when they breathe.
And how do these lower cancers spread compared to the upper ones?
Unlike the upward bilateral spread of the area above the cords, gravity and lymphatic flow dictate that these lower cancers drain straight downward.
Down toward the chest.
Exactly, toward the paratracheal nodes in the chest, specifically zone 6.
Okay, so let's say the cancer is above the vocal cords, and the surgeon wants to try to save the patient's voice box.
What the text calls conservation surgery.
Right, but the patient has to pass some intense physical tests first. The sources mention they heavily test the patient's cardiopulmonary reserve, checking arterial blood gases and pulmonary function.
Yeah, that step is non-negotiable.
I always hear the term arterial blood gases on TV. What is that actually telling the surgeon?
It measures how efficiently your lungs are exchanging oxygen and carbon dioxide.
Okay, but why does the surgeon care so deeply about your lung strength before operating on your throat?
Because of a truly harrowing trade-off. If they remove the structures above your vocal cord structures, like the epiglottis, which normally folds down like a lid to protect your airway when you swallow.
And there's no lid.
Exactly. You are going to inhale some of your food and drink into your lungs during recovery.
Aspiration.
Yes, chronic aspiration. Your lungs must be strong enough to essentially cough out aspirated food constantly.
Just to clear it out.
Right. And you have to tolerate that irritation without developing fatal pneumonia. If your arterial blood gases show your lungs are already weak, conservation surgery will kill you.
Wow. So what's the alternative?
They have to remove the entire larynx to completely separate the breathing tube from the eating tube.
That is heavy. But let's say their lungs are strong enough. They do the conservation surgery and those protective structures above the vocal cords are gone.
Okay.
How does a patient not just constantly choke on their food for the rest of their life?
Well, they have to completely rewire a fundamental automatic reflex.
Because you and I just swallow without thinking about it at all.
Exactly. These patients have to be explicitly taught and must rigorously practice a technique called the supraglottic swallow.
I was reading about this. Let me see if I have the steps right, because I want to walk you through what this actually looks like for the patient.
Go for it.
So think about eating a simple sandwich. Now imagine having to consciously perform a 4-step mechanical routine for every single bite.
Every bite.
First, you take a deep breath in. Second, you perform the Valsalva maneuver. So you bear down hard, like you're lifting something heavy.
Right, which forcefully clamps the vocal cord shut.
Using them as the new makeshift lid for your airway.
Exactly.
Third, while holding that intense tension in your body, you swallow the food. And fourth, before you take another breath, you immediately forcefully cough.
To blast away any food residue resting on top of those clamped cords.
Inhale, bear down, swallow, cough for every single bite.
That's exhausting.
Just the mental exhaustion of having to focus on that routine while sitting at a dinner table is staggering. It really highlights the sheer willpower required for recovery.
It really does.
And unfortunately, the sources make it clear that surviving the operation is just the beginning. The healing process introduces what has to be one of the most terrifying complications in head and neck surgery.
Yeah, we are talking about the pharyngocutaneous fistula.
So pharyngo for the throat, cutaneous for the skin, and fistula meaning an abnormal connection.
Right. When the surgeons remove a tumor, they have to stitch the remaining parts of the throat back together to form a closed tube.
Okay.
But if that suture line fails to heal properly, a hole opens up. And through that hole, saliva leaks out of the throat and directly into the deep tissues of the neck.
This brings us right back to that visceral scenario we started with at the top of the show.
It does.
The incidence rate of this happening is staggeringly high, sometimes up to 65% if the patient had prior radiation.
Because irradiated tissue loses its blood supply and just doesn't heal well.
But the stakes are what shocked me. Like, we swallow liters of saliva a day. It feels so harmless. But a saliva leak inside the neck is essentially a highly destructive acid.
To understand the biological reality here, you have to remember what saliva is actually for. It isn't just water to keep your mouth wet.
It's for digestion.
Yes, it is the first step of human digestion. It is packed with aggressive digestive enzymes, primarily amylase, which are designed to break down complex carbohydrates in tissue.
Oh, wow.
In fact, if fluid is leaking from a neck wound, doctors will run a test for amylase specifically to confirm it's saliva.
Because if it's saliva, those digestive enzymes are going to start doing their job on the newly sutured healing tissue inside the neck.
Precisely the danger. The saliva literally starts digesting the inside of the patient's neck.
And sitting right there in the neck is the carotid artery.
The main blood supply to your brain.
So if the fistula goes unchecked,
those enzymes will break down the tissue protecting the carotid. An exposed carotid artery, bathed continuously in digestive enzymes, will eventually thin out, weaken, and rupture.
that's terrifying.
It's known as a carotid blowout. It is an absolute catastrophic surgical emergency. The patient can bleed to death in minutes.
To prevent that, they have to catch the leak early. And the way they diagnose this leak is fascinating.
The blue dye test.
Right. In a field filled with multi-million-dollar PET scans and complex imaging, one of the primary diagnostic tools is basically a food coloring test, the bedside blue dye test.
It is incredibly low tech, but provides undeniable visual evidence.
How does it work exactly?
The patient swallows water mixed with methylene blue or just standard blue food coloring. The doctor simply watches the wound or the surgical drains in the neck.
And if blue liquid appears, you have a confirmed hole in the throat.
Exactly.
And the interventions to fix it are intense. The patient is immediately made NPO, meaning nothing by mouth.
You can't even swallow your own saliva, let alone food, so they divert nutrition through a feeding tube.
But the sources also mentioned treating the wound with negative pressure wound therapy. Wait, does that mean they attach a literal vacuum to a hole in the patient's neck?
That is exactly what they do. They pack the wound with a specialized sponge, seal it with an airtight drape, and attach a vacuum pump.
That is crazy. Is it just to suck the saliva away?
Not just that, the mechanism of negative pressure actually stimulates cellular growth.
Really? How?
By pulling the tissue edges together, it creates physical tension, macrostrain, and microstrain on the cells. This tricks the body into increasing blood flow and accelerating the growth of fresh granulation tissue to close the hole.
Okay, that is brilliant. But what if the vacuum still isn't enough?
Then the surgeons have to do major reconstruction.
Right, the sources talk about harvesting thick muscle flaps.
Yeah.
They will literally cut a section of the pectoralis major muscle from the chest or take an anterolateral flap from the thigh,
Yep.
and they move it along with its blood vessels up into the neck just to patch the hole caused by the saliva.
They need robust, healthy tissue with a pristine blood supply to combat the enzymes and protect the carotid.
It just underscores the immense physical trauma these bodies endure.
It really does.
Which naturally leads us to the final and perhaps most profound stage of this journey.
The voice restoration.
Yes, let's say they heal. The body survives, the cancer is gone. What happens to the patient's quality of life?
It's a massive adjustment.
The text states plainly that if a patient undergoes a total laryngectomy, where the entire voice box is completely removed to save their life, it is the loss of the voice that has the single greatest negative impact on their life.
It is a devastating loss. The medical field refers to the solution as a laryngeal speech, meaning speech without a larynx.
And the sources outline 3 primary methods to give these patients a voice again.
Right. The first is the electrolarynx. You've likely seen this. It's a battery-operated device held against the neck that transmits mechanical vibrations into the mouth.
Right, it's the easiest to learn, but it ties up one of your hands and produces a very robotic, monotone sound.
Exactly. Then there's esophageal speech. This requires no equipment, but it sounds incredibly difficult to master.
How does that one work?
The patient essentially has to learn how to actively swallow air into their esophagus and then burp it back up in a highly controlled, continuous way.
Oh, wow.
Yeah, that vibration of the tissue allows them to articulate words, but it requires immense practice.
Which is why the third method is currently the preferred gold standard, right? Tracheoesophageal or TE speech.
Yes, TE speech.
Yeah.
It provides by far the most natural sounding voice. This was revolutionized back in 1979 by 2 pioneers, Singer and Blom, who introduced the tracheoesophageal puncture or tip.
I am obsessed with the biomechanics of how this works. It's this elegant biomechanical bypass.
It really is.
To visualize this for you, in a total laryngectomy, the trachea, your windpipe, has been permanently disconnected from your throat. It's brought out to a hole in the front of your neck called a stoma so you can breathe.
Right, which means air from your lungs can no longer travel up through your mouth.
So to restore speech, the surgeons create a tiny deliberate puncture straight through the back wall of the trachea into the front wall of the esophagus.
They're connecting the windpipe to the food pipe,
And into that tiny puncture, they slip a small one-way silicone valve.
and the aerodynamics of that one-way valve are genius.
So when the patient wants to speak, they take a breath, cover the stoma in their neck with a finger or a special cap, and breathe out.
And because the air can't escape the neck, it is forced through the silicone valve into the esophagus.
As that rushing air travels up into the throat, it causes the mucosal lining of the pharynx to vibrate.
Right, they use their throat tissue as replacement vocal cords.
It's incredible. And because the valve is strictly one way, when the patient eats or drinks, the food goes down the esophagus, washes over the valve, but the valve stays firmly shut.
keeping the food from leaking into the windpipe and drowning the patient.
It's a brilliant piece of engineering. But taking a digestive tube and forcing it to act like a musical instrument comes with hurdles.
Definitely.
Because those throat muscles weren't originally designed for fine-tuned vocal vibration, they can sometimes spasm uncontrollably, making the resulting speech sound tight, strained, or hypertonic.
And the medical solution for that spasm is wild Botox.
Botox, like cosmetic Botox.
It is a highly effective off-label use. Under fluoroscopic guidance, essentially live X-ray imaging, the doctor injects about 100 units of botulinum toxin directly into the constrictor muscles of the pharynx.
To relax them.
Exactly. By chemically paralyzing those specific spastic muscles, the air flows smoothly, and the patient's voice immediately relaxes into a fluent conversational tone.
That is so clever.
Yeah.
But there's another enemy of the tip valve, and it's not mechanical, it's biological.
Right, yeast.
Specifically Candida, the exact same standard yeast that causes everyday fungal infections.
It is a relentless, ongoing battle. The environment inside the throat is warm, moist, and dark. It is a perfect incubator for fungal colonies.
So what does the yeast do to the valves?
It latches onto the silicone and begins to colonize it. As the fungus grows, it physically degrades the silicone material, warping the valve until its tiny doors can no longer snap shut properly.
Now, when that valve starts closing securely, the barrier is breached.
Yes. Liquids the patient swallows start seeping backward through the valve directly into their lungs, triggering violent, dangerous coughing fits.
So how do they find it?
Patients have to maintain a rigorous maintenance schedule. They use antifungal swish and swallow routines to beat back the yeast.
If it doesn't work?
If the yeast is too aggressive, surgeons have to use specially designed, much more expensive valves embedded with fluoroplastic materials similar to Teflon.
Oh, just to create a surface so slick the yeast can't grip it?
Exactly.
The cleaning, the replacements, the Botox injections, it's a massive commitment.
Yeah.
But when you think about the alternative, it makes perfect sense.
Completely.
Think about how much of your own identity, your humor, your authority, or your tenderness is wrapped up in the subtle pitch and tone of your voice.
It is the primary vehicle for your personality. To lose it is a profound trauma. The fact that medical science can create an artificial fistula, drop in a simple silicone valve, and give a patient a physical pathway to reclaim that human connection, to sound like themselves again, is nothing short of medical triumph.
It really puts the fragility of our bodies into perspective. Let's quickly recap the intense journey we've mapped out today.
Sounds good.
We started with the deceptive simplicity of hoarseness, exploring how a white patch of leukoplakia serves as an early warning sign of a disrupted mucosal wave.
Right.
We navigated the treacherous geography of the throat, discovering why the rich, storm drain-like lymphatic system above the vocal cords demands aggressive surgery and grueling swallowing therapies.
It's a supraglottic swallow.
Exactly. We looked at the terrifying biological reality of the pharyngocutaneous fistula, where digestive enzymes in saliva can turn into a lethal threat to the carotid artery.
And blue dye test.
Yes. And finally, we unpacked the miraculous aerodynamics of the tracheoesophageal puncture that allows a patient to speak again.
It is a remarkable testament to both the resilience of the human body and the relentless ingenuity of head and neck surgeons to preserve life.
It truly is. But I want to leave you with a final thought. The ponder, a hidden marvel that isn't explicitly detailed in the surgical steps we just discussed, but is happening silently in the background.
Ooh, I like where this is going.
We've spent this entire deep dive focusing on the physical mechanics, cutting out tumors, shifting thick muscle flaps from the chest to the neck, creating artificial holes, and inserting silicone valves.
The plumbing.
Right, the plumbing. But imagine the unseen neurological feat happening alongside all this.
The brain's capacity to adapt to this new anatomy is staggering.
Exactly. When a patient uses the tissue of their esophagus, powered by air force through a piece of plastic, to say, I love you to their family,
Their brain has had to completely rewire decades of deeply ingrained subconscious behavior.
it has to figure out, on the fly, how to articulate complex human emotion, subtle pitch changes, and the rapid-fire mechanics of language through a totally alien piece of anatomy.
The neuroplasticity required to turn a digestive tube into a nuanced instrument of emotional expression. It's profound.
Which brings us right back to the beginning. When we look at this complex medical world, we aren't just looking at the clear, simple lines of an x-ray.
Not at all.
These doctors and these patients are navigating murky, dangerous waters to not just fix a broken biological machine, but to completely rebuild the invisible essence of a person. Thank you for joining us on this deep dive into the source material. As always, stay curious.